Hi colleagues, welcome to this webinar, where my intention is to share with you some ideas and techniques that will hopefully stimulate you to use ProTaper next or to achieve better results in your practice with this unique root canal preparation system. My practice is in Johannesburg, South Africa, where I run the Studio for Endodontics, Restorative Dentistry and Dental Education, where I spend most of my time. I am also a part-time lecturer at the University of Pretoria in the Department of Odontology. So let's start off and first look at some general features of the ProTaper neck system. The file system is used in continuous rotation at about 300 RPM, and I like to set my torque to about 2.8 Newton centimeters for my clinical cases. The files have a 11 mm long handle instead of the conventional 13 mm that enables the clinician to do more complex cases when patients present with restricted mouth opening. The system also consists of 5 instruments that we will discuss in more detail, but in approximately 80% of canals, the clinician will only need 2 instruments, the X1 and the X2, to complete canal preparation. In the next few slides, we will focus on the benefits of the design of the instruments. The first design principle is that the files have an increasing and a decreasing percentage tapered design on a single file. If we look at the X1 instrument, you will note that the tip of the instrument is an ISO size 17 with a taper of 4%. Then the taper progressively increases to about 7.5% at D9, and then from D9 to D13, the taper decreases to about 6%. If we look at the X2 instrument, you will note that the tip of the instrument is an ISO size 25 with a taper of 6%, and then the taper progressively increases to about D9, it will be 7%, and then from D9 to D13, the taper also decreases to about 6%. So as I mentioned before, these are the 2 instruments that you will use in most cases to complete canal preparation. For larger canals, we also have an X3, an X4 and an X5 instrument. Again, you can see the respective tip sizes of ISO 30, 40 and 50 and the tapers of the instruments on this slide. Also note the decreasing tapers from D9 to D13 again. For example, if we look at the X5 instrument, the taper ends only at 4% at D13. There are 2 key advantages for this type of design on a single file. Firstly, it makes the instrument more flexible compared to an instrument that presents with a fixed increasing taper. And secondly, it allows us to create more conservative root canal preparations that also conserve radicular dentine in the pericervical area. The second design principle is that the instruments are manufactured from night-tie M-wire alloy. From the study from Johnson et al. In 2008, we know that the M-wire alloy improves the resistance to cyclic fatigue by almost 400% when comparing files with similar tip diameter, taper, and cross-section. Clinically, this means that the system demonstrates decreased potential for instrument fracture, and the M-wire alloy also provides you with more flexible instruments that allow you to treat more challenging cases safely in your practice. The third design principle, the offset massive rotation, brings along quite an unique file movement with some distinct clinical benefits. To demonstrate this principle, I'm going to show you a spinning top. This top illustrates the movement of a file rotating around the center of mass of rotation, for example, a ProTaper universal instrument. The spinning top on this slide shows the movement of an instrument manufactured with an offset mass of rotation, for example the ProTaper Next instruments. The offset mass of rotation movement creates a swaggering-like appearance when the file is rotated, as you can see on this animation. Also note that the tip of the instrument is not off-center, but centered during rotation to eliminate any transportation during canal preparation. The instrument also presents with a rectangular cross-section, and because of the offset mass of rotation principle, the file will only make contact with the dentine wall at 2 of the 4 contact points, as you can see on this slide. Again, the offset mass of rotation principle also brings along clinical advantages. If we compare a ProTaper Next file rotating in a canal compared to a conventional file like ProTaper Universal, also rotating in a canal, you can clearly see that there are decreased amount of contact points of the cutting blades with the canal wall due to the offset mass of rotation principle, so there will be decreased engagement with the ProTaper Next file compared to the conventional ProTaper Universal file that will result in increased engagement of the contact points with the canal wall. Clinically, this means firstly, less taper lock. Secondly, there will be less screwing in effect of the file when we prepare the root canal, and there will be a reduced amount of torque buildup on the instrument. In other words, we have a much more user-friendly type of file with a safer type of rotation during canal preparation. A further advantage of the offset mass of rotation is that it ensures more cross-sectional space for debris removal during canal preparation. If we look at this animation, we have ProTaper Universal F2 on the left side with a triangular cross-section and a ProTaper Next X2 instrument with its rectangular cross-section on the right-hand side. It is obvious on this animation that as the file penetrates down the simulated canal, that there is a lot more free space around the ProTaper Next instrument, the black space, compared to the ProTaper Universal instrument. This concept is also illustrated on this animation. Clinically, the additional space allows the instrument to maintain a high level of cutting efficiency, as a collection of debris around the flutes generally reduces the cutting efficiency of the instrument. In addition, you can also see that it helps to load and to auger the debris outwards during canal preparation. All these design principles leaves us with a system that provides us clinically with less hand fatigue because the instruments cuts effortlessly and very fast, and at the same time we require less instruments as mentioned in the slides before. It is important to note that if we compare the system to ProTaper Universal, that the ProTaper Next X1 instrument does the shaping work of both the S1 and the S2 ProTaper Universal instruments, and the X2 ProTaper Next does the finishing work of both the ProTaper Universal F1 and F2 at the same time. In general, our preparation time is decreased because of the increased cutting efficiency and because we have to change less time between different instruments to achieve our final canal shape. Just before we discuss the clinical guidelines on how to use the instruments, I want to show you a direct comparison with in-house data from Dentsply Mylifer between ProTaper Next and ProTaper Universal to emphasize why most clinicians prefer the ProTaper Next system. Firstly, there is a higher resistance to cyclic fatigue with ProTaper Next of about 60 to 215% compared to ProTaper Universal. There's greater flexibility with the ProTaper Next instruments, 20 to 60%. We see less transportation of about 35 to 65%. There's, as mentioned many times before now, that is a reduced working time because we don't have to change so many instruments and the instruments cuts very fast. About 17 to 30% reduction in preparation time. Because of the fewer instruments, we have improved access, easy to learn the technique, and we can use these instruments in complex cases to achieve great results. Now I want to go through the directions for use of the ProTaper Next instruments, and I'm going to use one of my clinical case reports to illustrate the sequence. Andrew, a 41-year-old male, reported with pain and discomfort on his upper right maxilla. Radiographic and clinical examination revealed non-vital upper first and second maxillary molars. For the demonstration of the DF use of ProTaper Next, I'm going to take you through the clinical steps for treatment only of the upper first maxillary molar. If we look at the CBCT scan of these teeth, we can see on an axial slice that there is a lot of bone destruction between the roots. And on the sagittal and coronal views, we can see large periapical periostitis around the buccal and palatal roots. Also note the involvement of the sinus and the thickening of the Schneiderian membrane on these slices. Before we proceed with this case, let's first talk a bit about canal negotiation. This is a key concept when we do a root canal treatment, to incorporate a cycle of negotiation, to always assure that a canal or part of the canal that you want to prepare is negotiable. Before this can be done, it is important to ensure patency of the canal. If a canal is not patent, then we should not take rotary preparation files into the apical third of the root canal system. After patency, we will create a glide path with hand or rotary instruments, and the last step will be irrigation and recapitulation that will be incorporated after each rotary instrument by taking a patency file to or past working length to ensure that the canal is still negotiable. As mentioned before, canal negotiation and glide path preparation is the first part of the root canal preparation and probably the most important part. I often find myself spending more time on this part of the procedure to get the canals patent before glide path preparation compared to the actual preparation with root canal preparation instruments. So allow me to highlight my step-by-step protocol for this phase of the treatment. As mentioned before, canal patency is the first step. I use a combination of 08C Plus and 08K files to negotiate the canals to patency. Some cases are easy and some cases are very, very difficult. I think that the inability to create patency to full working length is often the reason why we see so many poorly prepared and obturated root canal systems. On this video clip you can see that I've just achieved patency now. After that I will do my working length using an electronic apex locator. In some cases, the inability to negotiate the root canal system, especially for instance the MB2 canal and maxillary molars, is due to the presence of restrictive dentine at the orifice of the canal, causing the file not to enter with straight line access. A very effective instrument that can be used to remove restrictive dentine at this level is the XX instrument from the ProTaper Universal System. This instrument should be used in a backstroke brushing motion and never pushed down into the root canal system. The severe taper of 9 to 11% of this instrument can cause taper lock and fracture if it is used continuously with the wrong motion. The next step towards glide path preparation will be to create a reproducible micro glide path. As you can see from this slide, I like to divide the physical glide path preparation steps into a micro and a macro glide path. Let's first discuss the micro glide path. A reproducible micro glide path can only be prepared with hand instruments, small handsy instruments like a size 0.8 or 10K file, depending on the initial size of the canal. We have to understand that many canals have already a micro glide path present, but the problem is that they are not reproducible. Let me show you this example. On this video we have a size 0.8K file that can travel down the root canal to patency. However, when we pull the file back out of the canal and try to push it back to working length, it hangs up somewhere on the canal wall. This means that there is a glide path, but it is not reproducible. This diagram depicts these type of canals where there is a glide path, but it is not reproducible. And I like to refer to these glide paths as being irregular in shape. When we're lucky, or when the glide path is regular, it is possible to push a size 0.8 or 10K file to full working length very easily. However, the clinical challenge occurs when we pull the file back, as we saw on the previous video clip. It then hangs up on some of the irregularities on the canal wall. In these type of canals with an irregular glide path, it is advocated to take an 0.8 or 10K file to full working length, and then using small amplitudes, we have to make the file loose at 1mm, then up to 2mm, 3mm and 4mm from working length, according to the technique described by John West. The third step in glide path preparation is to check if we have indeed created a reproducible micro glide path with these small hand instruments. To confirm this step, it is advisable to take a 10K file to full working length or patency, withdraw it for about 4 to 5mm from working length, and then you must be able to push it back to working length with light finger pressure, without any obstruction in its path of travel towards patency. This verification process will confirm the creation of a reproducible micro glide path. Now we are getting to the last stage of glide path preparation, and that is to expand the micro glide path using rotary glide path instruments, for example path files or a single pro glider instrument. This will create an even smoother and more regular glide path, making the root canal ready to accept any root canal preparation instrument with safety and respect for the root canal anatomy. So let's go back to Andrew's case. On this video you can see how we expand the reproducible micro glide path with the Pro Glider instrument, a single progressively tapered rotary instrument for glide path enlargement. It is important to note that most of the research studies favor first using the Pro Glider instrument to expand the glide path before canal preparation with the ProTaper neck system. Here is an example of a study done by Baruti et al. In 2014 that demonstrated that by first using the Pro Glider instrument to expand the glide path, it will reduce the stress when shaping the canal with ProTaper Next X1, ensuring more safety and predictability during canal preparation. Now we can look at the second part of the root canal preparation process, namely canal preparation with the ProTaper Next system. The first instrument of the ProTaper Next system to use after glide path preparation will be the X1. In the presence of sodium hypochlorite, brush and follow along the glide path with the 1704 ProTaper Next X1 instrument in one or more passes until working length is reached. If after a few coronal insertions progress is not being made towards working length, then remove the file. This is followed by a sequence of first irrigation to remove the cutting debris from the root canal, followed by a recapitulation with a pre-curved size 10K file taking to working length or patency. The file is moved in and out of the canal to ensure that any compacted debris is loosened up and the canal stay patent. Lastly, this is followed by re-irrigation to remove the dislodged debris, leaving the canal patent and ready for the next cutting cycle. Before we proceed, it is also important to clean the cutting flutes of the instrument. Here you can see the typical loading pattern of debris on the flutes if the file was used in a wet canal. I like to use a sponge to remove the cutting debris from the flutes. On the right hand side, you can see that all the debris have been removed and the file is ready to be reinserted into the root canal for the next cutting cycle. In most cases, the X1 will reach working length during the second cutting cycle. The file is allowed to carefully work its way down to working length in each canal, as you can see on this video clip, using the same technique as described before. When the file feels loose at working length, it is removed from the canal. This is again followed by a cycle of irrigation, recapitulation and re-irrigation. We are now ready to introduce the next instrument, the 2506 ProTaper Next X2. I want to share with you a clinical tip that you can use as a guideline to check if you have done an adequate job with the X1. If you introduce the X2 and it is short of working length with a distance of about 1 to 3 millimeters, as you can see on this slide, you can assume that you've done an adequate job with the ProTaper Next X1 instrument. However, if you introduce the X2 and you are about 5 to 6 millimeters short of working length, you have to go back and create more space with the X1. Otherwise, I find that we tend to overstress the X2 to get it down to full working length. If you follow my guideline as outlined on the previous slide, then in most cases, the X2 will reach full working length in 1 or 2 passes. Again, irrigate, recapitulate and re-irrigate the canal to remove cutting debris. The next step will be to gauge the foramen with a size 25 night tie hand file. If the file is snug at length, the canal is shaped and ready for final disinfection. When we deal with wider canals, for example the palatal root canal in this clinical case of Andrew, we often find that the X1 will follow along the glide path in the presence of sodium hypochlorite, and usually in one cutting cycle it will easily reach working length. The canal is irrigated, recapitulated and re-irrigated. Now we introduce the X2, the 2506 instrument, in the presence of sodium hypochlorite. You will notice again that the X2 is used in a brushing motion to free up coronal space that will allow the file to progress further down the root canal. If it fails to progress, remove the instrument, clean the flutes and the canal with irrigation, recapitulation and re-irrigation before you proceed with another cutting cycle. After preparation with the X2, the foramen is again gauged with a size 25 night tie hand file. If the file fits snug at length, the canal is shaped and ready for disinfection. If the size 20 hand file is loose at length and it can go past working length, as we can see on this video clip, it is recommended to continue shaping with larger instruments. In this case, we elected to continue shaping with the ProTaper Next X3, the 3007, and when necessary, you can even follow up with the ProTaper Next X4, 4006, or the X5, the 5006, gauging after each instrument with a size 30, 40 or 50 night tie hand file respectively. So back to the case. In the palatal root canal, in this case, the size 30 night tie hand file was used to gauge the apical foramen, and it was found that the file fit snug at length, and this palatal canal was also then ready for final disinfection and for obturation. After final irrigation, it was decided to obturate the MB1, MB2 and DB canals with gutter core obturators. Size 25 verifiers were fitted in all the mesobuccal and distobuccal canals, and the fit was verified radiographically, as you can see on this slide. A ProTaper Next X2 gutter percha cone was fitted in the palatal canal and also verified radiographically, and that canal was obturated using the Calamus dual obturation system using the continuous wave of condensation technique. On this slide, you can see the obturation of the two mesobuccal root canals with size 25 gutter core obturators. Note that the obturators are placed in a slow motion, about 4 to 5 seconds of travel as we obturate each canal. Here is the immediate final result on the left, and on the right hand side a post-operative 8-month follow-up radiograph after treatment of the first and the second molar. The 8-month post-operative CBCT showed good healing of the periapical periostitis, and also clearly visible on the right hand side is that the sinus pathology cleared completely. Let's have a look at how the ProTaper Next system performs in research studies. There are many studies and I will just highlight a few of them. The first aspect I want to look at is the resistance to cyclic fatigue. In this study by Al-Nagi in 2014, he looked at cyclic fatigue resistance of ProTaper Next NiTi rotary instruments. He concluded that ProTaper Next had a greater resistance to cyclic fatigue compared to ProTaper Universal and the high-flex instruments, but not to the twisted file system. Also in 2014, Perez Higueras et al. Tested the differences in cyclic fatigue resistance between ProTaper Next and ProTaper Universal at the 5 and 8 mm levels from the tip of the instrument. They concluded that the ProTaper Next files will last significantly longer than ProTaper Universal files, with a probability of about 98% at all tested levels, except for the ProTaper Universal S1, which was significantly the most resistant instrument to cyclic fatigue at 5 mm from the tip. The next aspect to look at is debris extrusion. Here's a study by Koshak et al. In 2014 where they looked at apical debris extrusion of the ProTaper Universal and ProTaper Next systems. In this study, the ProTaper Next files was associated with significantly less debris extrusion when compared to ProTaper Universal. Here is a study where the authors Kapar et al. 2014 looked at an in vitro comparison of apically extruded debris of ProTaper Universal, ProTaper Next, twisted file adaptive and high flex instruments. The ProTaper Next and twisted file adaptive instrumentation systems were associated with less debris extrusion compared to ProTaper Universal and the high flex systems. I think that you will agree that canal shaping ability is quite an important aspect to look at. The first study I want to highlight here was done by Bertlein, Mattei and Schaefer in 2014. They looked at the shaping ability of ProTaper Next and BT Race NiTi instruments in severely curved root canals. They firstly concluded that all instruments maintained root canal curvature and that the ProTaper Next files achieved the fastest preparation time between the two systems. The second study on the shaping ability was done by Zhao, Shen, Peng and Hapasolo in 2014. They looked at root canal preparation of mandibular molars with 3 NiTi systems, ProTaper Universal, ProTaper Next and Wave 1, using microcomputed tomography. They firstly concluded that all three systems shaped root canals in mandibular first molars without significant shaping errors. And secondly, that the curved canals prepared with the ProTaper Next instruments demonstrated less apical transportation than the canals prepared with Wave 1 or ProTaper Universal. Another interesting study and more recent was done by Pascolini et al. In 2015. This was also a micro-CT study where they evaluated the shaping ability of ProTaper Next and the BioRace system in maxillary first molar teeth with curved canals. They made three important conclusions from this study. Firstly, that neither systems produce significant shaping errors in curved canals. Secondly, canal centering ability was significantly superior with the ProGlider ProTaper Next combination compared to the ScoutRace BioRace combination. ProGlider and ProTaper Next demonstrated more conservative enlargement of the root canal areas. This is represented by the top group, Group A on this slide. And on average, the ProGlider and ProTaper Next reduced the inner dentine wall thickness to a lesser extent than the ScoutRace BioRace group, and that is represented by the bottom three images, Group B. However, this was not statistically significant, but you can clearly see the differences on this slide. And thirdly, they concluded from this study that the offset cross-section did not influence the final taper. The ProTaper Next X2 instrument ended up in producing a 7% taper in the coronal aspect of the canals. This demonstrated that despite the fact that the instruments demonstrate the swaggering movement, it still maintains a 7% taper in the coronal aspect with the ProTaper Next X2 instrument, not destroying any excessive tooth structure and weakening the root canal prepared tooth. The last research aspect I want to touch on is crack formation in dentine. In this study done by Kapar et al. In 2014, they compared the effects of ProTaper Universal, ProTaper Next and HiFlex on crack formation in dentine. They concluded that all files created cracks and that the ProTaper Next files and HiFlex caused fewer dentinal cracks compared to ProTaper Universal. In another study done by De Deers et al. 2015, they did a micro-CT study on the effect of ProTaper Next and twisted file adaptive systems on dentinal cracks. They again concluded that the ProTaper Next and twisted file adaptive systems did not induce any formation of any new dentinal microcracks in their study. I think that all of you will agree that all this research correlates with our clinical findings and clearly illustrating the excellent clinical benefits when ProTaper Next instruments are used for canal preparation. In the next section of this webinar, I want to discuss how to manage challenging root canal anatomy using the ProGlider and ProTaper Next instruments. Here we can see a few examples of cases with challenging anatomy that was easily managed with the ProGlider ProTaper Next combination. However, in these canals, I used a different protocol compared to that we've discussed before. So allow me to share with you one clinical case to illustrate this protocol. Our patient, Fiona, a 42-year-old female, presented with a non-vital upper first maxillary molar. Also visible on this periapical radiograph is the severe canal curvature in the mesobuccal root canal system. We started canal negotiation with a 08K file and the file hanged up in the apical third at the point of maximum root canal curvature. In narrow canals, we often battle to get negotiation to patency, I would recommend that you use the Pro Glider instrument just in the coronal 2/3 of the canal or up to the point where the hand file hanged up. The Pro Glider is then used in a backstroke brushing motion in order to create more coronal space in the canal. You will be amazed to see that how many times this protocol enables the same hand file that hanged up to progress to full working length or to patency. Here we can see the periapical radiograph of my working length radiograph, clearly illustrating the complex anatomy of the mesiobuccal root canal system. Once we achieved working length and made a size 10K file loose to create a reproducible micro glide path, then you can go back to the Pro Glider to expand the glide path to full working length. On this video you can see that I'm using small backstroke brushing motions to expand the glide path before we will do canal preparation with the ProTaper Next instruments. After irrigation, recapitulation and a re-irrigation cycle, it is time to introduce the ProTaper Next X1 file into this challenging anatomy of this canal. In some cases you might find that the ProTaper Next X1 progresses normal down the complex canal, but in some cases you will feel from the tactile feedback, despite the coronal brushing motions, that the file still hangs up and does not really want to progress. On this video, you can see that I introduced the X1, brush my way down for a few millimeters, but then experience complete resistance, and I could feel that the instrument takes a lot of strain. In these situations, it is recommended to back out of the canal and follow with an irrigation cycle to remove debris and to check patency. Now here's my clinical tip. Instead of going back to the X1 for a second cutting cycle, I would recommend to you to introduce the ProTaper Next X2 and brush your way down to the same level as where the X1 previously hanged up in the canal. Then again, after that, check patency and irrigate and clean the flutes of the instrument. If you now go back to the ProTaper Next X1 after you've cleaned its cutting flutes, you will find that the X1 will progress very easily to full working length without any strain on the instrument while it prepares the apical third of the canal. I find this protocol a much safer way to introduce ProTaper Next instruments when I'm faced with complex anatomy. This is again followed with an irrigation recapitulation and re-irrigation cycle. We can now introduce ProTaper Next X2 again in a conventional way to prepare the apical third of the canal. We irrigate again and verify the canal shape with a size 25 night-eye hand file as we discussed previously. In this case I decided to obturate this curved root canal system with gutter core, and on this video you could see the fit of the verifier. This is the post-operative radiograph that illustrates the immediate post-operative result, clearly showing maintenance of the root canal anatomy in the mesiobuccal root canal system using this protocol that I've just described. Another question you might have is, what about larger diameter root canals? Do we still have to use all the files, and in what sequence? Let me share with you my guidelines for treating larger diameter root canals, but let's first summarize our previous discussions. In a canal where we start negotiation with a 0.8 or 10K file and we expand the glide path with Pro Glider, or where from start the size 15K file fits loose, we always have to start root canal preparation with the X1 ProTaper Next instrument. If a size 20K file fits loose in a canal, then there is no need for the X1, and I would recommend that you start preparation with the ProTaper Next X2 instrument. If a size 25 file fits loose in a canal, you can start preparing with the ProTaper Next X3. If a size 30 file fits loose in a canal, we can start the preparation with ProTaper Next X4. And if we have a size 40 file that fits loose in a canal, I would suggest that you only have to prepare the canal with ProTaper Next X5. Let me show you an example. This is Joan. She's a 45-year-old female that presented with a periapical infection due to inadequate previous root canal treatment, as you can clearly see on this radiograph. After removal of the previous gutta percha, it was possible to push a size 30 K file to working length and it felt loose inside the canal. So according to my recommendation, we will start preparation with the ProTaper Next X4 because a size 30 hand file fits loose in the canal up to working length. The canal was then prepared with ProTaper Next X4 to working length and the foramen gauge with a size 40 Nitai hand file. The size 40 Nitai hand file could be pushed past working length, indicating that the apical foramen is still larger than a size 40. The canal was then further prepared with the ProTaper Next X5, as you can see on this video clip. A size 50 hand file was then used to gauge the apical foramen and it fitted snug at working length. A ProTaper Next X5 gutta percha point was selected for obturation, and after proper irrigation sequence, the canal was obturated using the Calamus dual obturating unit. This slide shows the preoperative, the immediate post-operative, and a 6-month follow-up periapical radiograph of this case, clearly illustrating that the periapical pathology is busy disappearing and good healing will be expected in the next few months. The last clinical case I want to share with you is an example where a tooth presented with small and large root canal systems in the same tooth. Kerry, a 35-year-old female, presented with irreversible pulpitis due to a large carious lesion on a mandibular left second molar. A CBCT scan of this tooth revealed a C-shaped canal configuration with a large distal root canal system, as you can clearly see on these two axial slices of the CBCT scan. After removal of the decay and build-up with a composite resin, the mesial canals were negotiated with a size 08K file. When the 08K file was loose, I then progressed to a size 10K file and also made it loose in both mesial root canals. The distal canal was large and accepted a size 25K file and it felt loose inside the canal. The glide paths in the mesial canals were expanded using the ProGlider instrument. The two mesial root canals were prepared using the ProTaper Next X1 instrument according to the manufacturer's instructions as discussed earlier in this webinar. Canal preparation with the X1 was followed by irrigation, recapitulation, and then re-irrigation of the canals. The next preparation file for the two mesial root canal systems was the ProTaper Next X2. This file was again used according to manufacturer's instructions, following the same clinical protocol as discussed earlier. As mentioned before, the distal canal system, root canal system, accepted the size 25K file and it was loose. And according to my protocol for large canals, canal preparation in this case should be initiated with the ProTaper Next X3 file. A cutting cycle with the ProTaper Next X3 was initiated, and because the file progressed very easily to working length, it was decided to follow this up with a ProTaper Next X4 instrument, as you could see on this video clip. After gauging of the canals using a size 25 Nitai hand file, in the mesial canals and a size 40 NiTi hand file in the distal canal. Final irrigation was done using the EndoVac system from Cybron Endo, utilizing 3.5% sodium hypochlorite after the smear layer was removed with EDTA. After cone fit, the canals were obturated with matching ProTaper Next gutter perch-up points, pulp canal sealer cement, and a Calamus dual obturating unit. This slide shows the pre-operative and post-operative radiograph of this clinical case, treated successfully with the ProTaper Next system. Ladies and gentlemen, now that I've shown you how to deal with average root canal systems, complex and challenging anatomy, and larger diameter root canal systems, I want to summarize this webinar by showing you a few clinical cases that was done using ProGlider ProTaper Next combination protocol, and also focus your attention to the maintenance of the original root canal anatomy in these examples. In this case, a lower mandibular second molar that required root canal treatment, you can clearly see on the length determination radiograph that we have an S-shaped type of anatomy in the distal root. After preparation and obturation, it was evident that this anatomy was maintained after canal preparation with ProGlider and the ProTaper Next instruments. Here we see an example of an upper right maxillary first molar with a sharp curvature in the last 3.5 mm of the second mesiobuccal root canal system. This anatomy was again maintained after preparation and obturation. In this case, a lower mandibular left first molar that presented with 4 separate root canal systems. The curvatures was maintained in the mesial root canals as well as in the apical part of the distolingual canal after preparation with ProGlider and ProTaper Next. This was an interesting case. A lower left mandibular first molar with 3 distal and 2 mesial canals, again treated with ProGlider and ProTaper Next. Again, I want you to note the maintenance of the root canal anatomy in the mesial and distal root canal systems of this challenging case. And my last example, another mandibular left second molar that presented with curvatures in the mesiolingual and an apical curvature in the distal root canal. This complex anatomy was again maintained during canal preparation. These observations are also confirmed in an in vitro study done by Elnagi in Alaska, where they evaluated root canal transportation, centering ratio, and remaining dentine thickness associated with ProTaper Next with and without a glide path. They concluded that the combination of ProGlider and ProTaper Next instrumentation method revealed better performance with fewer canal aberrations when compared with instrumentation performed with PAF files and ProTaper Next or with the ProTaper Next system on its own. Allow me to conclude with the clinical advantages of the ProTaper Next system. Firstly, it can manage severe curvatures with confidence and respect of the root canal anatomy. It demonstrates reduced incidence of file breakage because of M-wire and because there is less taper lock of the instruments when we prepare canals. Thirdly, we use less instruments with a drastic reduction in preparation time. And in my opinion, we end up with cleaner canals with less smear layer and debris compaction due to the offset massive rotation principle of the ProTaper Next instruments. I think that you'll all agree that these are very important clinical advantages that we gain when we use the ProTaper Next system. I also want to invite you to my website www.studioforendo.com, and if you go to the education button, you can view a lot of these videos and clinical reports that were done with ProTaper Next. If you want to learn more about how I use the ProTaper Next combination, you can go to the ProTaper Next or the Glide Path button on the same page, and you will be able to download these 4 articles. Finally, I want to thank all of you for your time that you have spent with me, and hope that you will have a lot of successful preparations with the techniques discussed in this webinar. Thank you.